By the time I'm done with this talk, 10 women would have lost their lives to pregnancy-related complications, according to UN statistics. This number does not touch us all equally. The majority of these deaths occur in low to middle income countries and in women who identify with equity-seeking groups. Indigenous women in Canada are twice as likely to die from pregnancy-related complications. Black women in the UK are 5 times more likely to die from pregnancy and childbirth. Despite these staggering numbers, women's health research, and specifically women's pregnancy health research, remains severely underfunded and understudied. We live in a world where one of the most universal and profound human experiences remains buried in mystery and misconception. For over a decade in Canada, only 1% of research salary awards were directed towards women health researchers. In the United States, where 10% of women get pregnant every year, only 2% of research investments were directed towards pregnancy. Clinical trials for pregnancy disorder treatments are almost non-existent, and researchers pursuing those studies often face barriers in securing approvals and funding due to these studies being high risk. To add on to that, for many, many years on our very recent past, women have been systematically excluded from clinical trials based on concerns from safety to the alleged complexity of our hormonal cycles. This exclusion extended even to studies on diseases that predominantly affect women. And it also extended even to female laboratory animals in basic research studies in health. What this has left us with is a minimal understanding of women's health that leads to this minimal understanding of women's health during pregnancy. So if we take some learnings from preeclampsia, which I have nerded out on for 5 years during my PhD, preeclampsia is a disorder that only occurs during pregnancy, and what happens is the mom gets high blood pressure, inflammation in her system, and that can lead to organ damage. Preeclampsia can have severe implications on both the mother and the child. Every year, 76,000 women, and to give you an idea, that's almost 40% of women of reproductive age in Edmonton. 76,000 women die from preeclampsia every year. 500,000 children die from preeclampsia every year. The cause of preeclampsia is unknown. The only cure to preeclampsia is childbirth, which is not really ideal when you're 6 months pregnant. What you may not know is preeclampsia's impact isn't just confined to the present or the pregnancy itself. It casts a long shadow on the well-being and future health of the mother, the child, and generations to come. Women who have preeclampsia and do survive are 4 times more likely to experience high blood pressure later in their life. They're 4 times more likely to have a stroke later in their life. They're 8 times more likely to develop kidney disease in the next 10 years after the pregnancy. And not only do they experience increased risk of developing these complications, preeclampsia can also lead to them developing these complications earlier, allowing it to add years of damage to their bodies. These effects are not only limited to preeclampsia. Unfortunately, the majority of pregnancy complications can lead to long-term effects on the mother's health. For example, women who experience gestational diabetes are at increased risk of developing cancer of the lung, the breast, the thyroid gland, and the kidneys. And unfortunately, the long-term shadow of pregnancy disorders is also cast on the infants, predisposing them to lifelong chronic complications. Emerging research shows us that the strong influence of pregnancy conditions on children goes well into adulthood, shaping their physical, health, mental health, and well-being overall. Examples of that include the link between maternal stress or starvation and a higher risk of this baby growing up and developing schizophrenia later in life. Or the link between the mom having preeclampsia during pregnancy and the child growing up and having diabetes or heart disease, even 50 years later. So how does this work? 20 years ago, a physician named David Barker from the UK observed an intriguing pattern. Regions in England and Wales of low economic status showed the highest occurrences of heart disease. This puzzled him because heart disease was typically associated with wealth, sedentary lifestyles, overindulgent diets. To investigate, he analyzed health records of 15,000 adults. He stumbled upon an unexpected connection between being born with a smaller size, often indicating adverse pregnancy conditions, and developing heart disease later in life. This gave birth, no pun intended, to the developmental origins of health and disease hypothesis, or DOHAD. The DOHAD hypothesis tells us that babies in the uterus can change how their bodies work in response as an adaptation to their external environment. While our DNA stays the same, the field of epigenetics reveals how small chemical changes can switch our genes on and off, affecting how our bodies work. For example, a mom who is not getting the right nutrition in her pregnancy can affect the baby's hormones, like leptin, which control how the body uses energy. These changes can lead to long-term problems in her child with how the body manages weight and make someone more likely to become obese later in life after having a challenging environment during their pregnancy. Research on the developmental origins of health and disease is causing a significant shift in how we understand the origin of human traits and how and when they begin to form. The research is also changing the way we view pregnancy and women's health. It's not just biologists that are taking notice. Even economists, like Nobel Prize winner Amartya Sen, are recognizing the importance of fetal origins for populations' health and productivity. Sen writes, "Poor prenatal experiences sow the seeds of ailments that afflict adults." The DOHAD research is sparking hope for preventing major public health issues like diabetes and heart disease by targeting interventions during pregnancy. And this perspective demands a profound shift in how we prioritize health research. So as we can see, prioritizing maternal health research and women's health research is not just a matter of compassion and equity and inclusion of women, but it's also an investment of the future, building healthier families, communities, and societies for generations to come. We are on the right track. There have been so many initiatives, programs, investments, and efforts launched to prioritize women's health research. So how can you build on this momentum? Volunteer, donate, or advocate for groups dedicated to improving the health of women, mothers, and babies. The Women and Children's Health Research Institute, Women's Health Coalition, and the Alberta Women's Foundation are some local examples. Participate in community efforts to support pregnant individuals, especially those that are newcomers, financially disadvantaged, or equity-seeking. Work with local organizations to improve access to prenatal care, education, and support systems. An example of those is the Terra Center that serves young mothers in need. Educate yourself and others about the importance of your reproductive health and in participating in research. And finally, advocate for women, especially those from diverse backgrounds, to be included in medical studies. Do that and do more, because by the time now that I'm done with this talk, 10 women have lost their lives to pregnancy-related complications. Thank you.